Okay, here's the comment to the case history. So the name, right, principal diagnosis, correct, complication, correct, concomitant disease. Okay, name, yes, title page, done well. Passport data, we have name, age, gender, yes, passport data, correct. Chief complaints, pain in the abdomen, secondary. Pain in the abdomen can be either chief complaint or secondary complaint. They cannot be both secondary and chief complaint. Weight loss, you have to mention how much weight did he lose exactly, for what period of time. Shortness of breath, chest pain. These symptoms must be developed in future maybe. Cardiovascular, chest pain, dyspnea. How can you tell that dyspnea is a cardiovascular symptom? Why do you think that it can't be related to respiratory symptoms? Maybe we'll find out that later. Diarrhea. Yes, it might be a symptom. There is no term as improper digestion. The proper term for this condition is dyspepsia. What do you mean by dysuria? Dysuria includes a lot of impairments of urinary output. You have to if you say dysuria, you have to mention what exactly do you mean by dysuria. Why do you think that weakness and fainting are related to troubles with neurological system? Why can't they be caused by general condition? We don't know that. Pain in lower extremities. What do you mean? What part of lower extremity? When this pain occurs, during walking or during rest? Is this pain constant or periodic, severe, non-severe? You have to mention all that. This is incorrect. Rash on the hands. Okay, if you describe rash, first you have to mention which part of his hand, either dorsal part or palmar part. Hand, you mean the like arm, wrist, shoulder, what? If you're talking about rash, there are 18 types of rash described in dermatology. They can be spots, pigmentation, petechia, and many more. So if you're talking about rash, you have to describe exactly which type of rash, where is it located, and other signs. So this is wrong. History of present illness describes how the disease which caused chief complaints developed. It means that here you have to write when this pain occurred, what provoked this pain, for how long is he suffering from this pain, and all other things which are related to this point, because his disease is manifested by those complaints. And in this section you describe all the way where his disease began. Why do you think that he has esophageal atresia? How can a person who is 26 years old have esophageal atresia? How did he live for those 26 years? How did he eat actually? Or maybe he had a gastrostomy from child age. You don't mention that. This doesn't have trauma of lower third of leg, doesn't have any relation to his present disease. The patient is not a tobacco smoker. Okay, that's very good for him, but it doesn't have any relation to present illness. History of alcohol consumption also doesn't have any single relation to his present illness. So all this is wrong. Family history. Yes, he has some hereditary predisposition for ischemic heart disease. Okay. Undergone surgery for the lower extremity due to accident. What surgery? What exact type of surgery? Did he undergo amputation of lower extremity, or was it just surgical debridement, or was it metallosteosynthesis or some other type of surgery? You have to mention that. No signs of chronic disease. This patient has pain during urination, sleep disturbance, weight loss of unknown cause, shortness of breath, chest pain, dyspnea, diarrhea, improper digestion. Or do you think that improper digestion it's a normal condition for a person? He has also weakness and fainting of unknown origin and pain in the lower extremity and rash on his hands. So you mean that maybe he has some dermatological disease, or this rash on his hands might be a symptom by somehow related to his present illness. We don't know that yet. But still, you write here that there are no signs of chronic disease. But previously, you've mentioned a lot of signs of chronic disease. So this won't do. This is wrong. You are in contradiction with yourself in your case history. You don't mention if he has any allergies to drugs or some food products or some chemicals. That's very important in future. Physical examination, body temperature, face expression, okay, height, weight, BMI. You must mention units in which you measure BMI. BMI is measured in a very specific units. This is not an absolute number. You have to mention that. Subcutaneous fat. Okay, he has edema in the region of his eyes, chest, cheeks and chin. So this is an edema which is located on his face. This is a very severe symptom actually. I think you will develop that in future description. Muscles normal. What do you mean muscles normal? He's a bodybuilder or he's a photo model for Men's Health journal? What do you mean by that his muscles are normal? How can muscles be abnormal, or bones, how can they be abnormal? Pain in the joints of what exact joints of what lower extremity? Left, right, both? Joint, what do you mean by joints? Is it knee joint and coccyx joint, hip joint, or is this ankle joint and knee joint, or all of them or none of them? Joints which are situated on foot. You have to mention that if you describe this finding in your physical examination section. chest shape, abdominal musculature when lying on... What do you mean abdominal musculature when lying on his back? Abdominal musculature disappears when he lies on his back, or something strange happens to his abdominal musculature, or what? I can't understand absolutely what do you mean by this sentence. It's just a sequence of words. Delay in chest expansion, decreased vocal fremitus. Oh, but this is a symptom actually which is related to chronic obstructive pulmonary disease. And those previous symptoms you've described in the anamnesis section, they can also be related to chronic obstruction pulmonary disease. Maybe you will develop that. Liquid in pleural cavity, that's not even a diagnosis, and this is not how percussion is described. It is written in the manual very clearly how do you describe results of your percussion. First you have to give information about the tone of his percussion, if it's loud, blunt. Then you have to determine the limits, lower limits of right and left lung by intercostal spaces. You have to mention all that, and only then you can describe that in certain intercostal region of either right or left pleural cavity, we don't know that, you can describe that by certain percussion symptoms. We can suspect that there might be liquid in his pleural cavity. So this is this has absolutely no relation to percussion. What exact rails do you hear? There are certain types of rails which is described in the manual, and you've learned that in your internal medicine course. First. Second, you don't describe if he has vesicular breath or pathologic breath. You don't describe if he has any other auscultation abnormalities like voice of pleural training and other symptoms which were described in the tutorial. So those two sections are wrong. Visible pulse on carotid artery. Okay, that's a very significant symptom. Maybe it will be developed. It might be related to shifts caused by chronic obstructive pulmonary disease. Maybe we'll see that later. Pulse is not measured in millimeters hydrargium, because millimeters hydrargium is a physical unit to measure blood pressure. Pulse is calculated in beats per minute. You are a third course student. I have no comments on that. By the way, you also had to mention what is his actual number of heartbeats, what is his frequency of pulse, and are those numbers equal? Does he have or have no deficiency of pulse, comparing to heartbeats per minute? Second, it was described in the manual and in the tutorial how exactly do you measure the pulse and blood pressure in an academic form. So this has absolutely nothing to do with academic case history. pain in the left quadrant of the abdomen. There is no upper left quadrant of the abdomen. Abdomen, as you know, he has 9 regions. There are three major regions, which are divided in 3 minor regions. There is epigastric, mesogastric, hypogastric region. Epigastric region is divided in 2 hypochondric region and properly epigastric region. Mesogastric is divided in left and right lateral region and medially umbilical region. And hypogastric region is divided in left and right inguinal region and suprapubic pubic region. So if you're describing pain in the abdomen, you have to mention one or more than one of those regions. This is not a medical term. Later, there is pain in the lower abdomen. Lower abdomen is not a medical term. Later, when exactly later? 2 days after, 3 seconds after, or how? I don't see inspection, palpation, percussion, and auscultation section in this region, so it seems that like we don't receive any information. And more, your principal diagnosis is acute appendicitis. So if this patient really has acute appendicitis, then he must have certain symptoms of appendicitis. I've mentioned in the tutorial that in your academic case history, if you decide to write it on the topic of acute appendicitis, you had to describe at least 1 or 2 symptoms of acute appendicitis, which are detected by superficial and deep palpation of the abdomen. I've also described the mechanism how those symptoms occur, what is peritoneal irritation, what is muscular defense, and how it develops during appendicitis. So this section of case history totally it's considered absent. Presence of edema on cheeks, chin. How do you know that those symptoms are related to pathology of urinary system? This is questionable. You know only that he has edema in those regions. How is it related to urinary system? It's not obvious. Palpation normal. What exactly were you trying to palpate? What is normal? What organ of urinary system did you manage to palpate in this patient exactly? Kidney, ureter, paranephron, or urinary bladder? What? Pasternatsky's symptom what? Positive, negative, or what? Pain during urination. Okay, this is an important symptom. Actually, you have to describe if this pain occurs at the beginning of the urination, at the end. Is it related is it getting stronger during urination? Is this pain constant? When did this pain occur? And so on. So, okay, let it be pain during urination. How can you tell that his prostate is normal? What was the investigational method by which you've made a decision that his prostate is normal? In the digestive system section, you did not describe results of digital rectal examination, which includes palpation of prostate in males, as it was mentioned in the tutorial. So how can you tell that his prostate is normal when you didn't investigate it? For me, it reveals a secret. Normal testicles. How can you tell that his testicles are normal? By which method of objective investigation? Did you see them? Did you perform palpation? We don't know. Patient is conscious. Okay, great. Speech normal. Cranial nerve. Yes, okay. Let it be. Can walk. Okay, let it be. How can you tell that his hypophysis is normal? Did you see it or palpate it, or did you perform auscultation? This is a section of physical examination. What physical examination method did you use to make a statement that his hypophysis is normal? It also reveals a secret. Thyroid gland, 2 dots, loss of weight. This is a more secret question than normal hypophysis. What is the relation of his weight loss to thyroid gland? So, is his thyroid gland functioning normal or it's abnormal? If it's abnormal, how is this abnormality related to weight loss? If he has hyperparathyroidism and you think that it caused weight loss, why don't you describe a single symptom of hyperthyroidism? Where is the section of thyroid gland palpation, at least, or some objective, visible symptoms of hyperthyroidism? So this conclusion also remains ununderstandable. Exophthalm. Okay. Is this exophthalm related to thyroid gland dysfunction, hyperthyroidism, or is this exophthalm a separate disease? Maybe he has a concomitant eye disease which causes him exophthalm. Is this the exophthalm of one eye bulb or both? Right, left, if it's a single eye? We don't know that. What other findings? Other findings of what? No signs of what? What do you mean that pancreas is normal? If you describe pancreas in the section of endocrine system, it means that by somehow you've evaluated the endocrine functioning of the pancreas. It means you've measured his blood sugar or glycosylated hemoglobin, or you maybe examined the level of his serum insulin or glucagon, or you've measured some other endocrine hormones produced by pancreas. How can you tell that it's normal then? We don't know. After you've performed taking of anamnesis and physical examination, you proceed to preliminary diagnosis section, where you mention that his age is 26 and he is male. That's a great diagnosis, very informative. But what exactly is his disease? Is his disease is 26 years, or his disease is male gender? What exactly? Please specify. Complaints have absolutely no relation to preliminary diagnosis. Complaints have relation to anamnesis. Diagnosis, preliminary diagnosis, is conducted as a summary of anamnestic data and physical examination. You had to write down his complaints and symptoms which state that his disease might be acute appendicitis. But we don't see that. We see actually nothing here. Dysuria, abdominal musculature, what? Presence of edemas or exophthalm. Do you think that exophthalm is one of the main symptoms of acute appendicitis? Or do you want to tell that his abdominal pain is, or you want to tell that his dysuria and dyspnea cause him such pain that it results in exophthalm, or what? So preliminary diagnosis section is absent. This patient has no preliminary diagnosis because from your case history he didn't undergo proper physical examination. Okay. CT scan. For what purpose do you wish to perform him CT scan? I had to mention this in this section. Abdominal ultrasound. Okay. To get an overview of abdominal and pelvic organs. Do you want to know his radiologic anatomy, or maybe you wanted to find some precise medical information by attempt of abdominal ultrasound? Doesn't a CT scan provide an overview of abdominal and pelvic organs, or maybe abdominal ultrasound brings in something new comparing to a CT scan? We can't understand that from this section. Complete blood analysis. I don't know what it means. It's maybe that blood analysis can be incomplete. What do you mean as complete blood analysis? Is it only common blood analysis, or it's biochemistry? Do you want to measure the level of his cortisol, or maybe level of other hormones or neurohormones? What exactly do you mean by complete blood analysis is unclear. Urine analysis. What exactly do you mean as urine analysis? Urine analysis for what? For anabolic steroids? Or for what? Very interesting. You proceed from this to final clinical diagnosis. Final clinical diagnosis can be carried out only after you've performed differential diagnosis. I don't see a differential diagnosis section in your case history. After you've interpreted data from diagnostic procedures, I don't see any section where you interpreted the results of those diagnostic procedures. I can't see a single mentioning what diagnostic procedure did you use to distinguish the nature of his dysuria, dyspnea, weight loss, pain in the lower extremities as you've mentioned, and edemas on face and exophthalm. If you mention those symptoms, you had to do some additional investigations to examine the functioning of his thyroid gland, other endocrine system. You had to perform him either a chest X-ray scan or chest CT scan to find the cause of his dyspnea. You also mentioned that he has liquid in pleural cavity. By which method did you confirm that he really has liquid in pleural cavities. We don't know that, and actually we don't receive any useful information which advocates for presence of acute appendicitis in this patient. So this section is absolutely, totally incorrect. Also, there is a missing section of differential diagnosis and a section for interpretation of diagnostic data. Then you proceed to final diagnosis. You make this conclusion basing on I don't know what. We didn't see a single symptom of acute appendicitis in this patient. You didn't describe a single sign, single clinical or radiological or laboratory sign of peritonitis. How can you tell that he has acute pneumonia? You didn't perform him auscultation properly. You didn't perform him even a chest X-ray or any additional diagnostic method. Is this pneumonia on right side, left side, two sides? Does it affect all lung or certain lobes or segments of the lung? We still don't know that. So this section is based on nothing. That is why it is inappropriate. Etiology and pathogenesis of what? Of acute appendicitis or peritonitis or etiology of acute pneumonia. What are you talking about here? It is unclear. Due to foreign body. What do you mean as foreign body? Where is this foreign body situated? What is this foreign body? How did this foreign body got into the environment of the patient's organism? These agents results in appendiceal orifice, which results in inflammation. I can't understand that. Agents results in appendiceal orifice. What agents? How do they result? What does the appendiceal orifice has to do with development of abscess with peritonitis? If he has abscess, then he doesn't have peritonitis. If he has peritonitis, it means that his abscess no longer exists, even if it existed. So this is also, to me, it's a sequence of words. Further treatment may be okay. Treatment of acute appendicitis is surgery. Let's forget that we don't have a single symptom. We don't have a single investigation. Okay, let's just deal with it. You proceed to surgery. What is the name of those numbers? What stands for number 1? I can intuitively know that this is patient's name and age. What is this? Is this a diagnosis prior to surgery? Is it a post-surgical diagnosis? Is this the diagnosis which you found out during abdominal exploration, or is it something new? We don't know. What does the number 3 stands for? Department of Surgery. What do you mean by Department of Surgery? Okay, general anesthesia, primary surgeon. Yes, this is correct. Single port laparoscopic appendectomy. Wow, this is a really up-to-date, modern, quite sophisticated surgical procedure. That's good. If you found out about this procedure in some literature. Let's see the description. Supine position. Okay, patient lies in the supine position. Okay, yes. If you describe a single port laparoscopic appendectomy, you first of all you have to describe what technical device did you use for a single port. Was it a Covidian seals port, or was it a debris port, or was it the applied medical gel path, or maybe you know some other manufacturer of single incision ports? This remains unclear. What instrumentation and equipment did you use for laparoscopy? It still remains unclear. What energy device, what source of surgical energy? It also remains unclear. I've described a procedure of open appendectomy in the tutorial video because it's less technically challenging and therefore less information consuming for students of the third course. I know that it is hard to figure out all those technical specialities, but it was your decision to write about single port laparoscopic appendectomy, and in your description of operation you proceed to surgical procedure without mentioning by a single word anything which is related neither to single port, neither to laparoscopy. What was the purpose of writing this procedure? Did you want to show that there is such an approach, that it's sometimes used in modern surgical clinics? If so, why didn't you advance on this? Why didn't you describe it properly? Appendiceal mesentery released, okay. Dissected from appendix base, okay. And cecum, yes. Basis of appendix is identical, yes. Clamped. Transected and ligated. What about abdominal exploration? Did you find something new in the abdomen? Why don't you describe the clinical feature of acute appendicitis? Why don't you describe the place of local serous peritonitis? Where did this diagnosis come from? Did you have some additional findings during surgery? Did your surgery end up with placement of a drain, or you didn't place the drain? How did you finish the operation? How did you stitch the anterior abdominal wall in the place where you've previously positioned the single port? What was the wound dressing? What was skin preparation for the incision? We can't see that in your description of operation. That's why it is incomplete. Post-operative diagnosis. What does that mean? You mean that his diagnosis is diagnosis? This is something very, very, very strange. No, okay, no blood loss. That's great. That's a good surgery performed. Yes, very good. You described that the gross specimen is appendix with mesentery. You will further send it to pathologic examination, and you will then receive a confirmation that this is really a case of acute appendicitis. There is no tumor or no other disease which mimics acute appendicitis. Okay, painkiller. What painkillers? Maybe morphine or some other painkillers. What exact painkillers? I've told in the tutorial that you have to mention at least one NSAID or some other analgesic drug, and you had to write it in the pharmacological form properly. What antibiotics? This is plural form. You mean that he had more than one antibiotic? What exact antibiotic? Why did you decide to administer him more than one antibiotic? Maybe he developed abdominal sepsis, but we don't see that from anywhere in your case history. Where are his follow-up? Where is his follow-up data? What happened with this patient on postoperative day 1, 2, 3? What happened with his operation wound? How did it heal? Didn't he develop some infectious complications of his postoperative wound? What happened with the abdominal drain? What was the effusion from the abdominal drain, if it was present? When did you extract the drain, if it was present? When was he discharged? Yeah, discharged, okay. Discharged on the postoperative day 4. Stop intake of alcohol. Okay, that's a good recommendation. Case history was made. I don't think so. The diagnosis was made based on nothing. Patient undergone appendectomy. Okay, he really did. But we don't know if he had acute appendicitis. Discharged on day 4. Your case history is written extremely poor. I can tell that you did not either read the manual, you didn't watch the tutorial video I've made for you. I don't know what was your source of information for writing this case history, but this doesn't have anything, practically anything, to do with real academic case history as it was described in very multiple extended details. So for this case history cannot be evaluated satisfactory.